Get started. So welcome everybody to today's ACLP Virtual Journal Club session. The ACLP Virtual Journal Club focuses on articles from the ABPN's article-based continuing certification pathway for CL psychiatry. If you are ever interested in presenting at one of these journal club sessions, please feel free to let me know and we can certainly make that happen for you. So for today's journal club session, I am very pleased to introduce Dr. Monica Sadlanova. Dr. Sadlanova is an attending physician in consultation-liaison psychiatry for the cardiac ICU and the units of the Department of Cardiac, Thoracic, and Vascular Surgery at the University Medical Center Göttingen in Germany. Dr. Sadlanova serves as principal investigator or co-principal investigator in multi-center interventional and observational studies in cardiovascular research. Today, she will be discussing a 2023 article, which she served as the first author for, entitled Depression Subtypes in Systolic Heart Failure, a Secondary Analysis from a Randomized Controlled Trial. In terms of logistics, Dr. Sadlanova will speak for about 20 minutes, and then we should have about 8 minutes for discussion. So if you have any questions, please feel free to use the Q&A feature at the bottom of the screen. I'll try to get through as many of those questions as we can with the time that we have. So with that, Dr. Sadlanova, please take it away.
Yeah, thank you very much, Chris. Thank you for the invitation. So I will tell you a bit more about our secondary analysis from the Hopeful Heart randomized control trial. So let's start with some background about major depressive disorder and heart failure. So as you all know, we have several symptoms of major depressive disorder according to DSM-4 and 5. So we need to have one of the main symptoms, such as depressed mood or loss of interest or pleasure. And then we need to have several other symptoms, such as weight loss or weight gain, insomnia or hypersomnia, and, for example, symptoms such as fatigue or loss of energy. And when we look on the other side, what are the main symptoms of heart failure? We can see that patients have symptoms such as fatigue or weakness. They have reduced ability to exercise. Patients have, for example, also lack of appetite. Many of them have, for example, the typical symptoms such as shortness of breath, but also swelling of belly area and swelling in other areas of the body. What we can see when we think about the overlap between major depressive disorder and heart failure is that there are several symptoms that might be a kind of overlapping symptoms, especially loss of interest or pleasure, weight gain, but also fatigue and loss of energy is one of the main symptoms also in heart failure patients when we talk to the patients clinically, but also other symptoms such as diminished or cognitive dysfunction can be found in patients with heart failure quite often. Why is it important? For example, in our analysis, we performed a Latin class analysis based on patient health questionnaire. And we know that we have 9 items of the questionnaire. And on the right side, you can see the clinical benchmarks. So what we are interested in are especially the identification of patients with moderate depression or moderate severe depression and severe depression that we need to treat either with psychotherapy or with psychocardiological or cardiac psychiatry treatments or BCC treatments or even pharmacotherapeutical treatments if needed. What I would like to discuss just briefly, so we have several options how we can treat patients. This is a meta-analysis according to efficacy of CBT in heart failure patients. We can see that there was a significant improvement in patients using cognitive or CBT in comparison to usual care. So there is an efficacy in patients with heart failure when they have, for example, a depression. So we can use the treatment significantly. And there are several treatments that the most of you will know according to pharmacotherapy. So we have, for example, the SAT-HERT treatment or trial, so safety and efficacy of sertraline for depression in patients with heart failure. And we also know that in this trial there was not a significant difference between the placebo and sertraline, the treatment group, according to Hamilton Depression Rating Scale. On the left side, you can see the characteristics of the population or of the cohort. So most of the patients had kind of severe depression, severe also symptoms of heart failure, according to New York Heart Association class. So more than 70% or 60% had class 3 or 4. What about the inclusion criteria? That's quite important also for our analysis. So for this study, patients must meet the criteria of DSM-4, and of course they needed not just a score on back depression inventory in this study, but also they needed a diagnostic interview, so a structured psychiatric interview to assess major depressive disorder. When we move on to mood heart failure trial, so effect of escitalopram on all-cause mortality and hospitalization in patients with heart failure and depression, we can also see on the right side that there were no significant differences between escitalopram and placebo group according to reduction in depression symptoms on Montgomery-Åsberg Depression Rating Scale. And what about the inclusion criteria of patients with depression? So patients who were recruited for this study needed to meet a PHQ-9 score of 12 points or higher. By the time of the study, there was a protocol amendment, so patients needed to have 9 points or more on PHQ-9. And in this study as well, patients needed to undergo a structured clinical interview based on DSM-4. So what about our analysis and just brief overview about the study? So Hopeful Heart study was an efficacy study of BCC, so blended collaborative care treatment for patients with heart failure and depression. So what about the inclusion criteria? So in this trial, patients with systolic heart failure, so with the ejection fraction of 45 or lower, were recruited with the New York Heart Association class of 2 or higher. And they needed to have in the first inpatient PHQ-2 screen, short screen for depression, a positive score of at least 1 question. And then they were rescreened after 2 weeks in an outpatient setting on phone with PHQ-9. And as you can see on the right side, they needed to have to be randomized in the next step, a score of 10 or higher, to be randomized in one of the 3 groups, collaborative care for both depression and heart failure, or collaborative care for heart failure only, or usual care for heart failure and depression. So what about the population? In total, there were 629 participants in this study. So we have 251 in blended care group, 252 in enhanced usual care, and then in usual care 126. The mean age was 64. The primary outcome of the study was the mental health related quality of life at 12 months. Measured by mental component summary of the short form 12 health survey. And as you can see on the right side, the primary outcome, so we were able to see in this trial that the blended collaborative care intervention was significantly efficient in reducing or in improving mental health related quality of life in comparison to usual care, but there was not a significant difference in comparison to enhanced usual care. What about the other outcomes? You can see there was a significant improvement in depression symptoms, and we were not able to see any improvements, for example, in physical health-related quality of life or heart failure-specific quality of life, or, for example, the depression symptoms in males. There were in Hamilton rate scale, for example, improvement in females in depression symptoms. So what about the population? When we look at the cohort, and that was also the primary or the idea of our Latin class analysis. So we were on the right side able to see that around 40% of the patients had a PHQ-9 score of 15 or higher. And therefore, we just asked ourselves if there are a kind of Latin classes that we can identify, and if there is a Latin class that we can show that this class, for example, has an overlap between heart failure and depression, especially in the typical symptoms. Therefore, we performed a Latin class analysis based on PHQ-9 scores, and we were able to identify the best fitting model with 4 classes, Latin classes, and we call the classes mild, moderately severe, moderate, and severe. So it's very similar to kind of clinical benchmarks we were able to see. The scores were a bit different, and in this cohort, even though the inclusion criteria were quite strict, most of the patients, more than 50% of the patients, were in the mild class, Latin class. You can see it on the left side, having a mean of PHQ-9 of 11.4. And what you can see on the right side are the probabilities for the symptoms on PHQ-9. So, for example, in the mild group, the most patients had the highest probability of being or having the main symptoms of being tired, having poor appetite, and having sleep disturbances. And when you think about that, that's exactly what we were thinking about according to overlapping symptoms, because those are quite frequent symptoms in patients with heart failure. So what about other aspects? So we were also able to see what is the longitudinal changes in other symptoms, for example, in quality of life, or in heart-related or heart failure-specific quality of life and PROMIS symptoms. I think it's not surprising that we were able to see that especially patients with severe depression symptoms based on PHQ-9 started much lower in quality of life and improved over the 12 months. Or, for example, they had more depressive symptoms and improved also over the time. On the right side, we wanted to see if there are differences in cardiovascular and non-cardiovascular readmissions according to Latin classes. If there are differences between the classes, that was not the case. And according to death, it was a borderline effect. So we were able to see that it was nearly significant. And what's quite interesting is the mild and moderately severe group. So we had a higher percentage of patients who died in those 2 groups. And it's kind of interesting also for the discussion when we think about the consequences of that. So what I would like to discuss is actually the aspect of our first Latin class, the mild class, with a prevalence of 53%. So in this depression subtype, in patients in this group, the most of the patients of the cohort had a really high probability of especially symptoms such as loss or having little energy, sleep disturbances, or poor appetite. And the question is really, are those patients having really major depressive disorders, or do we have patients with overlapping symptoms with heart failure? That's maybe the first question we can discuss. And then we were able to see that especially the moderately severe, and severe subtype of Latin classes in our analysis were patients or clusters that have this depression and major depressive disorders specific symptoms. And what we discuss in the article as well, so there are a few other studies showing that there is an overestimation of depression, especially using questionnaires such as PHQ-9 when patients have a score of 10 or higher compared to using DSM-5 criteria. So what might be our conclusions? We also discuss in the article. So we think that it's quite important that future intervention trials consider the complexity of depression in patients with heart failure. In this case, also reduce ejection fraction, and especially that they consider the possible overlap between depression and heart failure symptoms, with inclusion only of patients with verified symptoms of major depressive disorder. And I think that also the strict restriction criteria of trial might increase the possibility to detect, for example, efficacy of non-pharmacological or pharmacological depression treatment in this cohort. Just a brief overlook, some of you know about this. So at the last European Society of Cardiology annual meeting, so there was the scientific session of the new guideline of clinical consensus statement of mental health and cardiovascular disease. And I think some of the aspects are quite important for our clinical work as well. For example, the active principle, also for the cardiologists or cardiac surgeons, for considering especially the importance of mental disease in this population. And there are also some recommendations how we can treat or how we can screen patients and treat patients, even including patients and or cardiological treatments with using psychocardiological teams, interdisciplinary teams, also in clinical care. And we have also some guidelines and algorithms in this clinical consensus statement according to depression or anxiety and post-traumatic stress disorder, how we can screen patients, how we should move on if patients have a diagnosis of depression or anxiety, and how we should treat those patients with medication or when it's the right time to switch the medication. They also touch some aspects such as frailty or, for example, geriatric assessments that might be needed in heart failure population as well. I just would like to introduce briefly some other blended collaborative care study that has been going on right now. It's the ESCAPE, a European trial right now for blended collaborative care in patients with heart failure, with psychological comorbidity or distress. So the patients in this trial do not need to meet criteria of major depressive disorders, and they need to have at least 2 or more comorbidities. So we expect the results next year. So let's see if we will be able to show that such a blended collaborative care can be helpful in patients with heart failure and psychological distress. Yeah, so thank you very much. Thank you also to all the co-authors, and I'm happy to answer your questions.
Wow. Yeah, thank you so much. So it sounds like the takeaway from this particular analysis was really that probably most of the folks who ended up in that study didn't really have major depressive disorder. And that may also be the case for other studies out there. I know there's always kind of this tension between trying to get enough participants for your study and trying to recruit enough participants, and then also making sure people, really meet criteria for depression. So I guess my first question is kind of a clinical one. So if you were thinking about kind of approaching a patient with heart failure who came in with depressive symptoms, Any thoughts about how you would go about trying to diagnose depression when there's a lot of this overlap between heart failure symptoms and depressive symptoms?
Mm. So what I really think for the clinical work, but also for clinical trial, it might be important to have the main criterias, right? That patients screen in for one of the main depressive symptoms criteria, what we were able to show either or depressive symptoms or loss of interest. And then we need, of course, to screen with instruments such as, for example, patient health questionnaires, but they probably need to have higher score. And then we need to have good clinical interviews that focus on differentiating symptoms between heart failure symptoms that we can also ask in the interview when those symptoms started, how is it or how the symptoms change over the time, for example, after initiating treatments for heart failure. So we need to differentiate between those symptoms in a clinical interview as well. But I think the main takeaway is we need the depression specific symptoms in the first line and then to differentiate between the symptoms a bit better of heart failure as well.
Great. One of the questions we have that's kind of along the same lines is, so the cohort of patients that were in the Hopeful Heart trial were recruited from an inpatient setting. Is
Mhm.
there any indication from your data or other data that depressive symptoms vary with heart failure severity?
Yeah, there are studies showing, of course, that patients having higher severity of heart failure also have more symptoms of depression. It's according to the symptoms of patients, especially shortness of breath. So when we think about our clinical work as well, that's one of the most difficult symptoms patients can experience, to have shortness of breath, when they try to kind of be at home or they move just a bit and they get more and more severe symptoms. So there are studies showing those kind of associations between the symptoms, and that's the tricky part, because at some point it's not that easy to say what is depression, what is heart failure, especially in these somatic symptoms that we still have in the diagnosis of major depressive disorders, right? That we
Hmm.
also need for example, scores for PHQ-9s. So that's the tricky part about that. But still, what we need to have, I think, are the really symptoms such as depressive mood, such as loss of interest, not just when patients report you, I just cannot do that. It's important to have also the information, I just don't want to do that. Yeah, it's not just that I can do that, I just
Yeah.
don't have the energy to do it.
Yep. Right, right. So it seems like even, I mean, asking questions to see how much the symptoms overlap with their heart failure symptoms, whether they line up kind of from a time standpoint, which ones kind of came first, and um,
Yeah.
all is very helpful.
Yeah, and I
Um,
think during the preparation, just one sentence about that. I was really thinking about that, if it might be helpful to have a checklist of overlapping symptoms that we maybe during the clinical interview, we have those checklists just to be careful with symptoms when we give patients a diagnosis of major depressive disorder. That's first. And second, I think the severity of depressive symptoms, it's quite important for those studies, especially pharmacological studies, because when we have patients with really mild depressive symptoms and maybe also moderate symptoms, that might be patients who do not have any kind of effects of our treatment. So we need to include patients with severe symptoms, moderate severe symptoms for such trials, and we need to be sure about that.
yeah, I know. I mean, this did make me think back. You didn't go into it here, but the Mood HF trial and Sad Heart CHF trial, um, only about 15% of patients who were enrolled in those trials reported a prior history of depression. So again, like, yeah, it does make you wonder whether or not those folks really had major depressive disorder or not, which yeah, makes me wonder whether antidepressants would work if we actually had people with major depression enrolled
Yeah.
in
And
the studies.
I mean, it's quite important because when you look at the clinical statement, also from the conference in Madrid, it's not a real recommendation to start with antidepressants. Of course, when you have the indication with severe depressive symptoms in heart failure patients, but still that's something what's quite important because it changes the evidence and also the clinical pathways how we would treat patients. Therefore, we need good inclusion criteria for trials.
Yeah. Okay, great. One other question was kind of about whether or not it might be better to use a different scale to kind of measure depression or screen people for depression than the PHQ-9, such as the geriatric depression scale or
Mhm.
the hospital anxiety and depression scale, something like that, to try to get away from all of the physical symptoms so much.
Yeah, I agree. I was thinking about that as well, especially the geriatric assessments are quite good in my opinion as well for especially such studies when we have a older population with heart failure. So I agree about that. And maybe we even need another instrument and questionnaires using both, kind of looking at overlapping symptoms, but also considering the depression symptoms. So we might even need a different tool for these cohorts. Yeah.
Cool. Maybe one other question. So, we saw some of the data. You said that CBT was kind of modestly helpful for treating depression. We have these two negative trials of antidepressants, the MOOD-HF and the SAD-HEART-CHF trials. If you have somebody in clinical care who has heart failure, who presents with depression,
Mhm.
what is your treatment approach? How do you think about treating that patient?
Mhm. So right now, for example, in Germany, we have a nice clinical pathway for a psychocardiological outpatient treatments that we see patient in a kind of low dose psychotherapy right now that we can treat those patients in a psychological way using CBT, for example, but also a supportive therapy. But then we can focus on the clinical symptoms as well, talking to cardiologists all the time, looking at the adherence, focusing on cardiovascular symptoms as well. And I think that's the way how to treat those patients because they have many somatic symptoms and it's not that easy to treat them just in one way. So we probably need these interdisciplinary approaches and clinical pathways such as blended collaborative care, where we focus on both the cardiovascular symptoms, psychological treatments, and patients can maybe also stay at home and get those treatments from a care manager or nurse. But with a good training in psychological treatment, for example, with a good supervision from a psychiatrist or a psychosomatic specialist. So I can imagine that those blended collaborative care treatments might be a good way to treat patients by the time. And of course, I mean, we have the trials, but still, in some cases, when we have patients with severe depression symptoms, we need also a psychotherapeutical treatment.
Yeah.
But we need to start with low dose, especially in geriatric patients, and we need to be careful with side effects.
Awesome. Well, we are at time, but so thank you very much again, Dr. Sadlanova, for such a great presentation. Our next Journal Club session will be in December. It's going to be focused on GI psychiatry, so please keep your eyes peeled for more information about that coming up. And otherwise, thank you everyone for coming to the virtual Journal Club session, and I hope you have a nice rest of the week.